Okay, thank you so much for having me. I don't know if this should be considered late breaking since many of you have seen this data already before, but I chose to focus more on the adherence and the cases of HIV acquisition in the Purpose 2 trial, which I'll be talking about. Okay, so here are my disclosures. And so we know HIV continues to disproportionately impact key populations and geographic regions, including in the US South, where you are today. And as Dr. Schwartz mentioned again and again, we're not always getting antiretroviral therapies to the people who need it most. And so, of course, also uptake, adherence to, and persistence on PrEP has been suboptimal in many populations. And so we need new PrEP options. And we know from our experience with HPTN 083, 084, that injectable PrEP has the potential to overcome barriers to adherence. And so Lenacapavir is a first-in-class HIV-1 capsid inhibitor that's able to be administered subcutaneously every 6 months. And so for Purpose 2, we evaluated the safety and efficacy of twice-yearly subcutaneous Lenacapavir for HIV prevention in cisgender gay, bisexual, and other men, transgender women, transgender men, and gender non-binary individuals, all of whom were having receptive anal sex with partners assigned male sex at birth. And so the study design was interesting. As many of you know, it used this counterfactual model. Participants were randomized 2-to-1 to Lenacapavir or daily oral TDF-FTC. And interestingly, as participants came into the study, they were screened for HIV. If they tested positive, a recency assay was conducted to determine the background HIV incidence. And so the primary analysis was HIV incidence in the Lenacapavir group versus background HIV incidence, and the secondary analysis was HIV incidence in the Len versus TDF group. And so for the assessments, quantitative HIV RNA was done at screening and baseline, and then real-time HIV testing with FDA-approved point-of-care testing, as well as central laboratory fourth-generation antigen antibody testing was done at screening, baseline, and all follow-up visits. Additionally, there was plasma storage for Lenacapavir PK, retrospective RNA testing, and dried blood spots for tenofovir diphosphate. And then a blinded adjudication panel looked at all HIV positive results to determine status and timing of infection. And then Lenacapavir adherence was defined as receiving Lenacapavir within 28 weeks of the prior injection. So there was really a 2-week window that participants were allowed to receive their injection, because injections should be given every 6 months or every 26 weeks. And then for a 10% kind of randomly pre-selected cohort of participants in the TDF-FTC arm, adherence was evaluated using tenofovir diphosphate from dried blood spots. And then similarly, there was a 10% PK cohort for Lenacapavir group looking at plasma concentrations. And for all folks who seroconverted, assessments were done for Lenacapavir PK, dried blood spots, depending on arm, and then retrospective RNA testing and resistance testing. So here are the baseline characteristics. 3,271 participants were enrolled in 7 countries, 4 continents, and you can see the baseline characteristics were similar between arms. I just think it's important to discuss kind of 2/3 were non-white, almost 2/3 were Hispanic or Latin ethnicity, 22% were gender diverse, and there were high baseline rates as well as high chemsex rates. And so for the primary results, there were 2 infections in the Lenacapavir arm and 9 infections in the TDF-FTC arm. That meant an incidence rate of 0.10 per 100 person years in Lenacapavir and 0.93 in the infections per 100 person years in the TDF-FTC group, relative to 2.37 infections per 100 person years in background HIV incidence. And so thus the incidence rate ratio was 0.04 for Len versus background and 0.11 for Len versus TDF-FTC, allowing Len to meet superiority criteria. Okay, so now to focus a little more on adherence. So as I mentioned, this was defined as receiving a Lenacapavir injection within 28 weeks of the prior injection. And so 90% of injections were given on time at week 26. And for week 52, 93% of injections were considered to be given on time. And then for the 10% TDF-FTC adherence cohort, you can see adherence was high but declined over time. So high adherence was defined as tenofovir diphosphate concentrations consistent with receiving 4 or more doses per week. And you can see at week 8, high adherence was seen in 82% of participants, but by week 26, it had declined to 67% of participants, and week 52, 62% of participants. I did just want to note that in the 9 seroconversions that occurred in the TDF-FTC arm, all of them either had tenofovir diphosphate below the lower limit of quantification, consistent with receiving fewer than 2 doses per week, or there was one who did not have concentrations, DBS, available, but that person was known to have discontinued TDF-FTC earlier in the study. And so for the lenacapavir plasma concentrations, what you're seeing here, the gray dots represent individual participants. The gray line is the median Len concentrations in this PK cohort. The dashed lines are the 5th and 95th percentiles. And then the dotted lines, IQ1 is the inhibitory quotient, or IQ1 is the lower dotted line, and the higher dotted line is IQ4. And so to talk about these participants a little more, participant A was a transgender woman who was engaging in transactional sex. She had latent syphilis diagnosed and treated at baseline. And the lowest measured lenacapavir plasma concentration for this participant was 23.8 nanograms per milliliter. So that's consistent with IQ 6.2 at week 13. And that is the time when she was diagnosed. So week 13, she had a positive rapid and central laboratory 4th generation antigen antibody test, a positive qualitative RNA test, and her viral load was 934,000 copies per ml. So when retrospective RNA testing was done, this was negative according to standard HIV testing, so lower limit of quantification, 20 copies per ml. But the single copy RNA test at week 8 did show 4.8 copies per ml. For participant B, this was a cisgender gay man who had rectal chlamydia diagnosed and treated at screening. This participant was diagnosed at week 26. What you can note here is lower overall lenacapavir plasma concentrations, and then this noticeable dip at week 8 to 5.1 nanograms per ml, or IQ 1.3, but higher subsequent concentrations prior to the HIV diagnosis at week 26. At week 26, the participant had a negative rapid test, but all other testing shown here was positive, and the viral load was 14,100 copies per ml. And then when retrospective testing was done, viral load from week 13 forward was negative, or backwards, I guess, and then as was the RNA single copy assay. Both of these participants had the N74D capsid mutation detected at the time of their HIV diagnosis. And so here is the adverse event frequency, which was similar between the two arms, with the exception of change in estimated GFR, which was more significant in the TDF-FTC group as expected. STIs were among the most common AEs. And then for injection site reactions, a total of 26 participants in the Len arm discontinued. That was 1.2%. And this was relative to 3 in the TDF-FTC arm. That's 0.3%. And I will say nodules were more common in the lenacapavir group and lasted a median of 183 days. I actually just saw a participant when I was in clinic. He was coming in for primary care when I went back to clinic between sessions today. And he was about to be due for his next Len injection, and his prior nodule was almost gone. So this median of 183 days, I think, is about right. So in summary, twice yearly Len was determined to be safe and efficacious for HIV prevention in this trial of highly diverse, in terms of racial, ethnic, and gender participants. Len does not seem to delay diagnosis or seroconversion, and discontinuation due to injection site reactions was uncommon. And here's just some more information. We've been talking about Lenacapavir under FDA review with the PDUFA date next month of June 19th. And we really do hope that Gilead will prioritize access for those who need it most, like they are saying that they will do. And I'm just going to close. I think I'm 30 seconds over, but just extending our gratitude to all the trial participants, including 22 who were recruited and participated here in New Orleans, and to the Global Advisory, Community Advisory Group that had a lot of input into the study design and the way the trial was conducted. Thank you.